We are going to learn about the last chapter of the musculoskeletal system today, and it is all about recognizing a joint disease, which we are talking more about arthritis and its related conditions. You have to understand that you know most of the times musculoskeletal system. Uh, Related any kind of a complaint is generally and most of the times it is related down to the joint pain. Okay, while we're learning about a lot of metabolic bone disorders, and we were learning about infections and tumors of the bones and fractures last time, which is generally mentioned down as osteopathic pain, right? Osteopathic pain is a pain that is actually originating from the bone itself. Well, if it might be happening because of a fracture that is happened down onto the shaft, or if it is happening because of any kind of symptoms or any kind of a compromise that is happening along the compartment of the muscles, or if it can be happening because of any kind of a destructive bone lesion, like loss of corticomedullary junction or any kind of a destruction to the cortex or any kind of a destruction to the periosteum would actually cause a osteopathic pain. But in that kind of situation, you actually have to understand that it is happening down only in a single bone. Well, in those conditions also, there might be a joint that might be involved, or it may not be involved. But you have to understand one thing here is that in joint disease, that yes, it will start up as the pain inside the joint, and joints are the main organs who has a very important function of doing the movement. Okay, a flexible movement, and there are so many joints present, and there are so many types of joints that are present, something like a hinge joint, pivot joint, a ball and socket joint, right? Syndesmosis, all these kinds of condition, they have to cause a pain that is related down to the function of these joints. For example, to say if we are talking about the knee joint, which is actually helping down in maintaining the locking of the knee, and also actually trying to maintain the bear down the weight of the upper part of the body, and the weight is completely taken down by the knee, which is actually transferred from the femur to the knee, right? So joint pain will generally be associated with any kind of a movement disorder. Okay, the flexibility of the joint, particularly it is related down to flexion and extension. Okay, flexion and extension. And when we are talking about the proximal joints, okay, most of the times the proximal joints generally can do adduction and abduction. So any kind of a restriction that is happening down along the joints, eh, along the joints will actually cause a joint pain. And what is the main reason for such kind of a pain or any such kind of a movement related abnormality is actually called as arthritis. Arthritis can be simply said as the inflammation. Okay, arthritis can be simply said down as inflammation that is related down to the joints. Okay, inflammation of the joints is called as arthritis. Okay, so we are going to talk about, okay, we are going to talk about joint related problems today. Okay, just give me a second. So, in the joint disease, we are going to first start with the examination techniques. Then we are going to talk about the anatomy of a joint. Then we are going to see some of the basic and very, you know, famous diagnosis that is very frequent down in a hospital. So we will try to complete off this whole chapter because this is a very fairly easy chapter when compared to the other conditions down in the musculoskeletal system. So first we'll start up with the examination contents. Okay, understand one thing that radiology actually plays a very important role in the diagnosis and management of arthritis like conditions. Okay, uh, arthritis, though it may be called as the inflammation of the joints, you have to understand that there are a lot of clinical and non-clinical conditions that may actually cause this joint related inflammation. It can also be happening as primary disorder that can be starting from the musculoskeletal system itself. It can also happen not only from the musculoskeletal system, it can be happening also because of the secondary conditions, okay, secondary clinical conditions as well. Okay, any kind of an inflammation response, if it is happening inside the joints, is actually called as arthritis. So which means to say it can be localized condition or it can be related down to a systemic condition. So that is what exactly I meant by clinical and non-clinical. You can actually say it as primary arthritis or secondary arthritis. Okay, but if the diagnosis is much more related down to the musculoskeletal system in origin, yes, you might be calling it as primary arthritis. But secondary arthritis, it can be happening because of a systemic condition. For example, to say classical example we always have is rheumatic heart disease. Okay, or you call it as rheumatic fever. And in India, like conditions, we also have some other conditions like chikungunya. And then we also have a very famous condition like systemic lupus erythematosus. All of them are also related down to arthritis. So arthritis is a fairly a radiological observation rather than saying it as a disease or a diagnosis. Okay, most of the times when we are talking about in this chapter is that we are going to talk about the primary arthritis conditions, okay, which is actually showing up as a primary cause inside the musculoskeletal system in origin. Okay, so that's how we are actually trying to learn about this one. And for that kind of conditions, actually, yes, joint radiography is fairly plays a very important role. Well, the first thing we actually try to ever look inside a joint radiograph is that we are going to find out arthritis, right? Arthritis are the ones that we are actually going to find out. Well, any kind of a disease that is related down to joints is actually called as arthritis. And inflammation in particularly we're going to talk about is arthritis. For example, to say when we are talking about a condition like achondroplasia, when we are going to talk about ankylosing spondylitis, or when we are going to talk about rheumatoid arthritis, or when we are going talking about reactive arthritis, when we are talking about infectious arthritis, or when we are talking about gout, all these conditions are togetherly are called as arthritis. But inflammation happening particularly is called as arthritis, which is primarily divided down as three conditions, which is as rheumatoid arthritis. The second one is osteoarthritis, and the third one is reactive arthritis. I think you must have actually understand what is the difference between the arthritis and arthritis. Arthritis are the conditions. Okay, it can be happening because of so many other secondary scenarios as well, which are actually diagnosed on clinical and laboratory backgrounds. Okay, they have to be checked on clinically, they have to be checked along with the laboratory investigations, and then imaging is actually used to document the severity, extension, and course of the disease. See, for example, to say, let us try to take a clinical condition, and so that we can actually understand what exactly we are talking about here. Well, uh, let's say simply a 53-year-old female has been complaining of, okay, right-sided knee pain for the last 1 month. She has come down to the hospital, and the doctor has checked her knee, and came to find out that there is mild grade of tenderness upon palpation of the knee. Okay, is a little bit of a swelling around the knee, and mild, uh, so little swelling upon the knee, and there is a mild increase in the temperature upon the knee. Right? She does not particularly complain any kind of a joint stiffness, but actually complains that there is a momentary problem when she is walking for long distances. Okay, so that's what a 55-year-old female comes down to the hospital for a particular right sided knee problem, pain. Okay, so what do you think? The only complaint we have is right sided knee pain. So, what do you think on this condition? Yes? Can everybody hear me? Yeah, then tell me the answer. Okay, somebody is thinking about arthritis, somebody is thinking about osteoarthritis. Okay, right. So, most of the guys are actually telling us arthritis. Okay, so how are we going to confirm based on clinical examinations and based on laboratory investigations? Okay, forget about the radiology because it is the next step. Before, first we have to make sure that it is clinically arthritis. We have to make sure that it is laboratorically arthritis. So how are we going to confirm what are the symptoms, or what are the other conditions that we are going to expect if it is related down to arthritis? Okay, blood test, that's fine. What blood test would you do here? Ra factor, okay. ESR, okay. CRP, okay. Then anti-CCP, okay. What is anti-CCP? Okay. See, X-ray is the last step. I'm talking about the investigation that you can do first rather than uh, later. First, we are talking about the clinical conditions, right? Okay. So, right. Okay. Then let us try to break down every single step of it. Okay. Physical, to check the range of motion. Okay, why does only Reshma think that this is necessary rather than going for all those blood tests? Anybody agree with Reshma? No, Debalina, you don't already agree because you have already wrote a prescription for CRP, anti-CCP. So if you agree with her, you should actually have said physical and checking out the range of motion, redness, stiffness, swellings, all other things before you write your prescription. You already wrote your prescription in a business module rather than doing the physicals first. See, actually, only one person is correct here. Actually, Reshma is correct because she is thinking about doing a physical examination to check out the range of motion, to check out the redness, stiffness, and swelling. All other tests actually may not show you anything unless and until, for example, to say, if it is related down to the reactive arthritis, only in such kind of a clinical situation, you are going to see the high raised values of ESR and C reactive protein. Okay. If it is going to be a rheumatoid arthritis, yes, you are going to see a positivity of rheumatoid factor, right? And if you are going to look at for anti-CCPs also, yes, unless and until it is related down to rheumatoid arthritis or osteoarthritis, yes, even that one is also not coming positive. So if everything came out negative, but still pain is there, so what are we talking about here? Yes, if I'm doing on physical examination, I also check that there is a mild grade of swelling, okay, a mild grade of redness, and a little bit of stiffness when she's trying to, trying to move. Okay, when he's only when there is a uh, when she's trying to go for a long distance. Okay, that is the only time that she's going to find all of these kind of symptoms. So what exactly are we talking about here? Do you still believe that she needs an X-ray right now, or no, she doesn't need any kind of an X-ray? Will you go for an X-ray examination here? You will go for an X-ray examination. Okay, what are you expecting down on an X-ray? What are you going to confirm? You're going to confirm that there is no disease, or you're going to confirm that there should be some disease? So for confirmation, in such kind of a situation, you expect it to be normal, or you expect it to be abnormal? I'm sorry. Synovitis? What is the confirmatory diagnosis for synovitis? Shafiq, what is the diagnosis for synovitis? For synovitis, we are actually going to extract, okay, we are going to extract the synovial fluid and look for the turbidity of the synovial fluid. Okay, what is Panus formation, Shubham? What is Panus formation? Is there any fracture that causes swelling and restricted movements, so we have to do X-ray? Well, see here, one thing you are thinking all about bigger diseases, which may not be technically true. Any idea, Reshma? What are you looking for? You are the one who said, I'm going to look for the X-ray and I'm going to confirm something. Okay, what are you going to confirm here? See, we are not going to confirm anything. The only thing you see here, I am expecting it to be normal. Okay, I am expecting it to be normal. Well, even in such kind of a situation, it can be called as technically normal. See, if it is a strained ligaments could cause pain, and to confirm that one, you actually need to go for an MRI, right? So, which means to say, we are first. You said that okay, first I will start up with the simple blood test. Then you wrote CBP, ESR, rheumatoid factor, ASO titers, and then you also put her on, anti-CCPs, all things. Okay, five uh, tests, which actually cost you something around like 1,200 rupees already. And right now you are trying to put her on an X-ray, which generally is 600. Okay, but right now, later when you saw all these conditions and because of hearing my question, so that's the reason you wanted to put her an MRI, which is going to cost her something around like 6,000 to 8,000 rupees. So who came down to a OP clinic? Okay, let us say if I'm working in a village, she came to an OP clinic where generally the OP clinic has got an OP consultation fees of something around like 50 to 150 rupees. So she started with 150 rupees and now she's ending up with a bill of 8,000 to 10,000 rupees. Still no medication yet, no diagnosis yet. So do you think that this is a fair justification? Obviously, no. See, we are not going to confirm anything. Okay, if I wanted to confirm something, I wanted to confirm one thing, that there is nothing existent on an X-ray. There is no disease that is present on an X-ray, so that is what I wanted to confirm, right? And the other things I'm going to confirm, yes, you are going to talk about a panis formation, but technically you don't call it as a panis formation here. You are going to talk about hypersclerotic changes. We are going to see a little bit of changes of osteosclerosis. Osteosclerosis is the sense in that there is an increased density of the bone, but particularly this is not some kind of a metabolic bone osteosclerosis like condition. We are going to look for the abuse of the joint, overuse of the joints. And if there is an overuse of the joints, what technically I am going to find is that only certain parts of the joints, articular surfaces, are going to show up osteosclerotic changes, okay, which actually indicates that there has been an abuse. But nobody asked me a simple question: is she obese? Nobody asked me a simple question: is there any kind of a problem with her walking? Nobody asked me this question. Somebody asking me this question, yes, I would have said that there has been a postural problem and she has been utilizing her right knee a lot and she is a little bit of overweight, which actually can be happening just because of physical examination. While Dr. Reshma is looking for swelling, joint stiffness, and other things, but she forgot to notice about her physical status, which actually she might be an obese, and she didn't ask me about that one. So that's the reason she again down went for an X-ray and she stuck. Did you understand? Actually, most of the actually why I told you this kind of whole story is that most of the times joint related conditions is not related down to osteoarthritis or rheumatoid arthritis or any kind of a primary or secondary conditions, but most of the times joint related problems might be happening because of overuse. A simple thing which is called as overuse. No, it is not bursitis. Bursitis is actually happening because of a fat pad or a bursa that is present between the tendons and that is actually being inflamed because of a condition like trauma or friction. which is also happening because of overuse. But generally, bursitis is a condition which can be happening more in sports injuries rather than generally old age. But if it is related down to old age, yes, you can actually call it as bursitis as well. We'll talk about bursitis too. But yes, bursitis can also be seen. It can be seen as a secondary condition rather than a primary condition here. The first and foremost condition we are going to look for is the abuse of the joints. Well, she has already told you that she has been having a joint pain which is aggravating, and the tenderness and swellings are being aggravated when she is trying to walk for long distances. So, when she is going to go for long distances, how long is a long distance? Right? That is the first question should come over, right? If you are walking for 1 kilometer, no, that should not be a long distance. If you are walking for 4 kilometers, yes, obviously it's a long distance. If you are walking for 2 to 3 kilometers at the age of 55, right, and being a little bit of overweight, yes, obviously it is the abuse of the joints, right? So for most of the people, actually, we need not do this X-ray and even confirm that one. Actually, the only thing I am going to do is a physical examination and then put up her on normal analgesics. Okay, a basic painkillers, which are NSAIDs. I'm either going to choose for aceclofenac or paracetamol, or I am going to choose a COX inhibitor, right? So see, basic upon the response based upon the therapeutic doses of paracetamol, okay, and then uh, there is a there is it is a non-steroidal anti-inflammatory drugs. Paracetamol, a basic painkiller, acetaminophen should be able to manage this condition. But if it is not going to manage this condition, we are going to talk about we are going to choose some kind of a COX-1 or COX-2 inhibitors, right? So that is what the main clinical condition. So rather than going for all kinds of investigations, you see here, we can actually basing upon the clinical and laboratory grounds, we are going to decide if it is going to look for an imaging diagnosis or not. And imaging is generally utilized only if we are going to look or estimate the severity, extension, and course of the disease. So that's what it is. So I think right now you got a pretty good idea how we are actually going to proceed in this clinical condition, right? Okay. Now, what exactly does these conventional radiographs do? Conventional radiographs generally demonstrate osseous abnormalities, right? But only provide, okay? I told you, right? The diagnosis is abuse, okay? Joint abuse, right? Overuse, right? Yes. Okay. See, and actually they demonstrate osseous abnormalities, but only provide indirect and usually delayed evidences of abnormalities involving the soft tissues, such as synovial lining of the joint, articular cartilages, muscles, ligaments, tendons, and surrounding the joints. So, if you wanted to find out the delayed abnormalities, okay, well, unless and until there is a lot of abuse or a lot of insult that is related down to the joint, yes, such kind of abnormalities may not be evident on a plain x-ray. So in such kind of a situation, yes, MRI is used to demonstrate these soft tissue abnormalities. For example, to say, let me say it like this. Well, I think you actually don't know about this clinical condition, but actually, let me introduce you to this clinical condition. A 5 year, or not, let us not say 5 year, okay, a 8-year-old female, okay, 8-year-old female has been complaining, okay, has been complaining of the left-sided knee pain, okay, for the last 20 days. On physical examination, nothing is abnormal. there is a knee pain for the last 15 days. So, what is that you're thinking about? See, like I always said, don't tell about the investigation first. First, tell me about the diagnosis you might be thinking, and then you tell me that, yeah, x ray may be necessary or not, okay? You see here, generally, this is not going to, generally, you are not going to make up this diagnosis, okay, which is technically not a, I mean to say, the diagnosis at your level, okay? Well, condition, actually, what I am looking for here is a very, very simple diagnosis, okay, which is a very, very famous disease, okay, which is actually called as Osgood Schatter's disease. Ever heard of this name? Okay, remember, this is a very, very famous diagnosis, okay, this is a very famous diagnosis. It is actually the inflammation of the patellar ligament. It is the inflammation of the patellar ligament that is actually happening because of the abuse or sports related down injury, especially in the children. Well, it can also happen in the young, older adults as well. Okay, it is actually the main reason is the abuse, but it is the inflammation of the patellar ligament for particularly, which is actually causing a painful tenderness over the ischial tuberosity. Oh, sorry, the patellar tuberosity, tibial tuberosity, not ischial tuberosity. No, it is symptomatic. It is symptomatic. It is symptomatic with a painful tenderness over the patellar ligament. Okay, a painful bump or a painful swelling that is present over the tibial tuberosity is actually the symptom of this condition. Well, on examination of knee, you can actually find no such kind of a thing. But actually, when you move more distally towards the tibia, actually, that is the place where you can actually, that is the insertion of the quadriceps muscles, right? So that is the place where you actually find out this tenderness. Particularly when you are trying to look at the joint orientation, no, you are not going to find any kind of abnormality because you see here, I think any kind of a child, at a playful age, or any kind of an adult who has been actively working down in the sports, let us say an athlete or a sprinter, what actually you do is that most of the times children fall on their knees a lot, don't they? Right? Children generally hit their knees over a wall, or sometimes hit their knees over a floor, right? A lot of, you know, abuse is going on, and every time they are going to get scratches over their knee, and this kind of repeated injury that is actually happening on the knee, either for both a sports person or a young adult, okay, a child particularly. Well, it is happening because of all the adventurous children, all the adventurous children, particularly if it is going to happen in males. Okay, it is usually happening in males, but yes, females, adventurous females, yes, particularly for sure, it is actually called as Osgood-Schlatter disease. Osgood-Schlatter disease is an inflammation of the patellotibial ligament. Okay, inflammation of the patellotibial ligament, which is generally shown up as a little swelling over the tibial tuberosity. And that one is going to cause an inflammation, and that is the one that is actually going to cause pain over the knee. Did you understand this diagnosis? Generally, in such kind of a condition, yes, you are going to look either a normal x-ray or an abnormal x-ray depending upon this clinical condition. But generally, To diagnose such kinds of diseases, we are going to look for an MRI. As simple as that. Did you understand this? Right? Remember the name, it is actually called as Osgood Schatter's disease. All right? Which is a very, very famous clinical, diagnosis. Well, the management is actually done by painkillers. Okay, it's a normal anti-steroidal, non-steroidal, anti-inflammatory drugs. So that's the only thing we're going to do. Right. Now, so MRI, why actually I told you about this disease is that we are going to talk about if there is a condition that we are going to suspect that is related down to the soft tissues, synovial lining of the joints, and articular cartilages, muscles, ligaments, and tendons surrounding the joint. All of them, we are not going to look for an X-ray, but we are going to look for an MRI. Right. So first, we are going to learn about the anatomy of the joint. Particularly, I'm talking about the radiological anatomy here. Okay, first you have to understand that the articular cortex is thin, white line as seen on a conventional radiograph, which actually lies within the joint capsule and usually capped by the hyaline cartilage, which is actually called as the articular cartilage. Okay, and the bone is immediately beneath the articular cortex, and it is actually called as the subchondral bone. Okay, you have to understand here one thing, that the articular cortex, okay, wherever the cortex that is present along the articular side, which means to say I am talking about the proximal part of the distal bone and distal part of the proximal bone. You see, you understand, a joint is a joint is a connection that is present between two or more bones. Yes or no? So, what are the parts that are involved inside a joint? Okay, there will be, let us say, if we are talking about the knee joint, okay, the distal part of the femur is associated or is articulated with the proximal part of the tibia, is actually forming the knee joint. Yes or no? Right? Yes or no? Okay, it is the distal part of the femur which is trying to make a relationship with the proximal part of the tibia, right? So which means to say the articular surfaces, okay, the cortex that is present down in all along these articular surfaces, which means to say the distal part of the femur, yes, it has got its own cortex, and the cortex that is present down there is actually called as the articular cortex, which is present in the side of the joint. Well, it is similar, the same cortex of the main bone itself, but actually, since it is present down along the surface of the joint, so that's the reason along the surface to make the joint, we actually call it as an articular cortex. Well, which is actually thin and it is seen as a white line. Okay, and it actually has to lie within the joint capsule. Okay, it is not seen laterally, it is actually seen inferiorly, and it should be present down in the joint capsule, and it is usually capped. Okay, it is usually capped. There is a covering above it. Okay, immediately above the articular cortex, okay, immediately after the bone ends, there is a cartilaginous tissue that is present, which is actually made up of hyaline cartilage. So, which this cartilage is actually called as the articular cartilage, and you actually call this also as the articular surface. So, remember once again, articular cortex is looking as a thin and white line, and then it has to be present down within the joint capsule, and it should be covered by the hyaline cartilage, which is actually called as the articular cartilage. And the bone immediately present down to it, which is actually consisting of the epiphysis, metaphysis, and the diaphysis. So such thing is actually called as the subchondral bone, right? So what is the subchondral bone that is present down in the knee joint? What is the subchondral bone that is present in the knee joint? tibia, right? Or, okay, what is the subchondral bone which is present proximally in the knee joint? Femur. See, right now, did you understand? Anywhere that is actually articular surfaces are present, okay, those are the ones that are actually called the subchondral bone. Okay, let's try to understand here one thing. You look here, this is the diaphysis, this is the metaphysis, and this is the epiphysis of the joint. Sorry, epiphysis of the bone, right? And immediately above to it, there is a present down as a thin white line, which will actually show up as the articular cortex. So this is the articular cortex, which means to say this is the cortex. Obviously, it is a part of the bone, but actually, it is actually the one that is actually forming the articular surface. So which is actually called as the articular cortex. And immediately it is covered by a joint capsule. Okay, articular cortex should be present down within the joint capsule, and they should be present down within the articular. Immediately there is a covering over this articular cortex, which is actually called as the articular cartilage. Okay, and this is actually made up of hyaline cartilage, and all of them are covered by a joint capsule. Okay, this is the joint capsule, this is the whole joint capsule, these are covered by the joint capsule. So this is the articular cartilage and this is the articular cortex, and immediately the surface that is present below it is actually called as the subchondral bone, right? Epiphysis, metaphysis, and diaphysis, right? So that is how this whole organization is. So any kind of a problem that is happening within particularly these regions is actually called as a joint disease, right? So it is present down in the synovial membrane, and what is the fluid that is present in between? Actually, it is the synovial fluid that actually is present between a joint. Okay, in between two bones, there is a synovial joint, and in that joint, there is a synovial membrane, and inside the membrane, there is a synovial fluid, right? And the main important function of the synovial fluid is actually to maintain the friction, right? Reduce the friction that is present over these articular surfaces. So it is actually acting as a lubricant, right? So that is actually the composition of a joint. Right now, in the in the radiographs, we are actually going to look at. You see here, this is actually okay. Can you somebody tell me what is this joint? What kind of a joint is this? What is this joint and what kind of a joint is this? Okay, what joint is this? Does that look like elbow to you, Shafiq? What joint is it? Anybody? It is a knee joint. Okay, is it right joint or a left joint? Right side, left side? Is it right side or left side? Okay, it is a right side knee joint. Actually, I can say it is a right side knee joint because I'm looking at the tibia and the fibula. Okay, this is the fibula that is present down laterally. Okay, so it is a right sided knee joint. Okay, Synovial fluid reduction in the knee always related down to the age. Well, most commonly related down to the age. Okay, it is most commonly related down to the age. Right. You see here in this radiograph, what we are actually trying to look, actually, the synovial fluid is present here. Okay, this is the distal part of the femur, and this is the proximal part of the tibia. And here you can see that there is a thin white line. Okay, and particularly you are also going to see here, this is a thin white line. This thin white line generally is actually your articular cortex. Okay, and immediately above that levels is actually you are also going to look at the bone is of increased density. Okay, and you can also see that there is this which is in relation down to this articular cortex. Okay, this thin white line is the articular cortex, and immediately below that one, or immediately in relation to that place, actually I am going to also see that there is increased densities. Right, you see there is an increased density along these areas. Right, and that one is actually called as the subchondral bone, and that one is actually called as a subchondral bone just because the uh, it is called as a subchondral bone because there is actually uh, distribution of the stress, or the distribution of the weight of the region, or distribution of the thrust or the force towards the subchondral regions of these bones related down to the joint. Okay, because any kind of a stress that is actually happening along this articular surface is going to transferred is going to get transferred to the subchondral regions of the bone. Right, so that's the reason we actually call this one as this stress taking area. Right, so these are the stress taking areas, and stress taking areas generally have a dense trabecular pattern, or a dense trabecular network, and those dense trabecular networks are the one that actually look become more whiter. Right, so did you understand this? So this thin white line is actually the articular cortex, and this is the articular surface. Right, and immediately above it there is also the subchondral bone, and there is a black hypolucency that is present in between these two articular surfaces, particularly speaking today the distal part of the proximal bone and the proximal part of the distal bone. So both of them, in between them there is a space which is actually called as the joint space, and that is the place where the synovial fluid is present. So this is a normal orientation of a joint. All right, so is this points clear here? Right, and here we're going to look at an MRI of a joint. Okay, the MRI, we are actually going to look at the T1 weighted coronal image of the knee joint. Actually shows up the medial and the lateral menisci. Actually there are meniscus that are present which are actually the articular cartilage. Okay, these are the articular cartilages. All right, so meniscus, there is a meniscus that is present down in the knee joint, actually, which is the medial meniscus and the lateral meniscus. Okay, medial meniscus, lateral meniscus. And then we are going to look at the cruciate ligaments, which is the anterior cruciate ligament and the posterior cruciate ligaments. And then we have the articular cartilage. Right, this is the articular cartilage. Okay, and then we have we have the joint capsule. You see here, this is the joint capsule. This is the joint capsule. And then we have the cortex of the bone. This is the cortex of the bone. Right, joint capsule, cortex of the bone. Right, and then we have a synovial fluid here. So all the ones actually you look here, we are actually looking at a T1 weighted image where all the fluid actually tries to look black. Okay, and all other things technically try to look white. Okay, so here this is what I'm trying to look at, the articular cartilage. Okay, this is the articular cartilage. The black dotted arrow is the articular cartilage, and this one is the joint capsule. A dotted white arrow is the joint capsule. And then I'm going to look at this one is the synovial fluid. Okay, this one is a black hypointense. Okay, this is a synovial fluid. Okay, and then I'm going to look at the subchondral bone here, which means to say this is the articular cortex, right? And then I'm going to look at two structures, which is the anterior cruciate ligament and the posterior cruciate ligament, whereas this articular cartilage is actually showing up as the medial meniscus and the lateral meniscus, right? So this is a technically a true composition of an knee joint. All right. So is this point clear? This is nothing but general simple anatomy, right? Okay. So the lining of the joint capsule is the synovial membrane. Lining the joint capsule is the synovial membrane, which is actually containing the synovial fluid. The synovial membrane is frequently the earliest structure that is involved in to form an arthritic reaction. Okay, so joint capsule, in the joint capsule there is a synovial fluid, and the synovial membrane and the synovial fluid are the ones that are going to get affected in case of an arthritis. Okay, conventional radiograph generally will demonstrate abnormalities of the articular cortex. Remember, this is a very particularly a quite uh, peculiar sign of arthritis. Okay, conventional radiographs should relate or should demonstrate that there is an abnormality that is present down on the articular cortex, okay, and the subchondral bone, and should provide late indirect evidence of the integrity of the articular cartilage. See, any kind of abnormalities that is present over the articular cartilage actually suggests that there is a late indirect evidence which is actually related down to the integrity of the articular cartilage. So, which actually means to say, if the integrity of the articular cartilage is lost, which most of the times it is happening because of an abuse, generally we call that condition as arthritis. Well, but it is happening, it may be differentiated down into the rheumatoid arthritis and osteoarthritis, which actually has to be associated with a lot of other clinical symptoms and also late changes. Okay, if there is no late changes that is related down to this articular cartilage or the articular surfaces, you generally don't call it as arthritis, but you generally call it as an abuse. Did you understand this now, the difference? Well, yes, before when you were talking about the 55-year-old female, yes, arthritis could be the condition that is related down, but you cannot confirm it as, and you cannot categorize it as osteoarthritis or rheumatoid arthritis unless and until there are changes that are looked, there are particularly evidence of a loss of abuse and a loss of integrity of the articular cartilage loss is not seen. So then we are not going to call it as an arthritis. If late changes or if particular features of the arthritis are not seen, we generally don't call it as arthritis, and in such all such conditions we actually call it as an abuse. Is this point clear right now? Yes. Later on stages, okay, in few years later, actually she will obviously develop arthritis, that is for sure. But right now she hasn't actually having all these problems that is related down. Any kind of abnormality is not evident over the articular cortex and articular cartilage. Integrity of the articular cartilage still seems to be particularly normal. So that's the reason I don't call it as arthritis. But later on stages is she will be developing arthritis as well. So here when I'm talking about arthritis, I may be talking about rheumatoid arthritis and rheumatoid osteoarthritis. Okay, so and also The unconventional radiograph, the synovial membrane, the synovial fluid, articular cartilage are generally not visible, but they are visible on an MRI. And MRI, for this kind of a reason, because synovial fluid, synovial membranes, and articular cartilages are soft tissue structures, and they are not visible on an X-ray unless and until there is a lot of inflammation, right? So, even to find out the minute changes that is related down to these soft tissue structures, we are going to prefer an MRI. And we always know MRI has got more sensitivity, directly visualizing all the soft tissues in and around the joint. Okay, which is means to say we are talking about the bursa, we're talking about ligaments, tendons, muscles, right, nerves, and synovial membrane, articular cartilages, and even fluid. Okay, so all these structures can be clearly demonstrated by MRI because it has got better sensitivity towards all these structures. And so that's the reason MRI is the preferable choice of sensitivity. Okay, let us say gold standard, particularly. But however, choice of investigation is always a conventional radiograph. Okay, choice of investigation, or you can actually say the first study of investigation is actually a conventional radiograph in evaluating the presence of an arthritis. So in this particular chapter, we are going to look for only the plain radiography features of arthritis conditions. Okay, now let us take a break here. Okay, and then we will come after 15 minutes. It's 11:40 in my clock, and then we will try to meet around 11:55, 12 o'clock. All right, 10 to 15 minutes of break.